Okay, welcome back, everybody. And next speaker is Dr. Demian from Asheville, North Carolina. He'll be speaking about peroneal nerve dysfunction in spinal care.
Hello, does this work? Got it. Yeah, so I'm Demian. I'm in Asheville, North Carolina. I've only been there a year, though. I actually practiced in Wyoming for a long time. But so I'm a spine surgeon, but this is an interesting topic to me because I kind of discovered it later in my career and didn't realize sort of the impact that it's actually had on the outcomes of a lot of my patients. Okay, so just a brief, obviously we've got to go over the anatomy. Sciatic nerve comes down, it splits into the posterior tibial nerve, and then you get the common peroneal nerve that comes around the around the lateral hamstring here and around the lateral aspect of the gastroc. Okay, and when it comes here, it becomes pretty much subcutaneous as it passes over the proximal fibula. Okay, and then it splits into a deep and a superficial branch. And the common portion doesn't really have a motor branch, but after it splits, the deep and the superficial innervate the respective compartments that they lie in. Okay, the anterior compartment, the lateral compartment of the leg. So the superficial goes into the lateral compartment of the leg where the peroneal muscles are for ankle eversion. The deep stays in the anterior compartment of the leg and innervates, the anterior tibialis, the extensor hallucis longus, and the muscles that we usually check when we're doing a spinal examination. The innervation is really from L4 to S1. So, I went over this. So where does this come from? So I guess I'll just backtrack a little bit and talk about why this is interesting to me. Because a lot of times, I'm kind of focused on taking care of the spine, right? And I do peripheral nerve work. I do carpal tunnels and ulnar nerves and things like that too. And I still do like fracture work. But I think what I realized is a lot of times, someone would come in with an L5, S1 problem or L4, 5, and I take care of that, and they don't get full return of the function. They still have some type of clinical issues going on. And those times I'm like, boy, I re-image them, I'm looking for anything else I can find, and then it kind of dawned on me one day that a lot of times when we get myelopathic patients in, right, they come in, their hands are numb, they've got palmar numbness, they're losing function. We do this, corpectomy or whatever we do, and they make quite a recovery, but they still have numbness in their hands, right? And it turns out to be carpal tunnel a lot of times, and we release that, and they get more function. Kind of like a double question on these things, okay? So I started kind of looking for that in the lower extremities, and when I started to find it, I started trying to look it up, and I really can't find much information out there on it, okay? So where does it come from, this mononeuropathy? So really, it's the number one mononeuropathy of the lower extremities. So it's the third overall after ulnar nerve and carpal tunnel. And obviously we see it in traumatic issues with knee dislocations or penetrating trauma or proximal fibular pathology or fractures, and especially in compartment syndrome that as an orthopedic surgeon I usually call to care for. We can cause it, okay, iatrogenic, taking care of a large valgus knee deformity, and we can actually put that on stretch if it's been that way for a while. Doing total hip replacements many times, you can stretch the sciatic nerve and people develop a foot drop. And other things we do to people, placing splints or casts, compression wraps, sports socks. They talked about this habitual leg crossing. I'm one of those guys. I'm sure if I don't get this, but prolonged bed rest, obviously. So obviously systemic factors can really play into the systemic illnesses, can make the nerve much more fragile. Okay, so diabetes, thyroid disease, vascular issues, alcoholism, inflammatory conditions, motor neuron disease, And this one's interesting, anorexia. So with, I think the more kind of like the superior mesenteric artery that you have, kind of can happen down here at your knee. You can lose the fat pad, and so the nerve kind of makes more contact with the proximal fibula. So this is kind of my thinking. This is sort of like a double crush phenomenon that we see. And that's where two lesions with little or no independent clinical ramifications that combine, it leads to a magnification of the symptoms. Okay? And there's theory of how it works, the axoplasmic flow. But anyway, in my practice, we didn't really have a very good, we had a neurologist that did EMGs, but he wasn't really his thing. And then we hired a pain management guy that was, and he's the one who really started like kind of finding this for me. He's the one who kind of triggered my thought process on this. So obviously, when you see a patient in, the clinical examination, you look for sensory. So once again, the deep branch, okay, the superficial branch, maybe I should go back. The deep branch kind of dives deep and stays in the anterior compartment and pops up and gives sensory between the web space of the first two toes, okay? I think of it kind of like when you put a flip-flop on. If you lost your deep, you can't feel it. The superficial is more the lateral aspect of the calf. So, but it's interesting, a lot of these people do just have symptoms from their knee down, but just like carpal tunnel, like you said, you can get like shoulder pain. So it can really kind of mask itself. Then if it gets really bad, it's develop a drop foot, they get foot slappage, or a steppage gait, they have to bring it up and over, or the vaulting, where they actually use their other foot to kind of help bring the foot up and over, or circumduction. I found this actually quite helpful, just performing a tenellus at the proximal tibia. It's quite easy, the nerve is superficial. I do all the carpal tunnel ones, and I don't know, sometimes it works for me, maybe not really good at it. But this one seems to be a little bit more reproducible in my hands anyway. So obviously the diagnostic testing, okay, I do rely on EMG and nerve conduction. And I really make it, I request that the person who I'm sending to, this is what I'm looking for. I'm trying to differentiate, is this lumbar, is this peripheral, is this a combination of the two, can you help me? And with that information, I think it seems to help me get a more accurate answer. I was going to talk a little bit about EMGs and nerve conductions, but I think that was sort of already covered. So one thing I do though is I do image them, okay? Because I have seen local pathology that causes this, and I don't want to go in there blindly. So there are, you start with a simple X-ray. There are various bony tumors or bony growth, osteochondromas. One patient actually was interesting that I don't have a picture of that. She was the wife of an emergency room doctor that I worked with quite a bit. And she had a proximal tib-tib joint cyst, okay, that had grown out, was compressing her nerve. So sometimes you do find things. This is a schwannoma, okay. Here's a stress fracture of the proximal fibula. This is the nerve actually coming across. So I do think imaging has some role, if it's warranted, especially by the history. And then treatments. Obviously, there's non-surgical treatment with physical therapy, where they try to do mobilization, neuromobilization, stretching. They look at the angles of the foot and the overall alignment of the knee and things like that. But really, what I'm here to talk about is surgery. Okay, what I do is pretty much like doing a carpal tunnel with an ulnar nerve release. You find the nerve, you trace it up, you trace it down. And there's actually 3 little fibrous bands. Okay, there's an anterior, a posterior, and an unnamed. And Dr. Susan McKinnon is out of St. Louis. Okay, she's got some really good videos on this. And matter of fact, that's who I took my wife to when she needed this surgery. Okay, I did one on Monday. Then we got on the airplane and flew to St. Louis to have hers done on Tuesday. So, but anyway, this kind of demonstrates, this is a pretty large incision. but you go down and you find there's a little fascial band, okay, just kind of spread the tissues, and once you find the nerve, you just follow it, you can follow it proximally distally. And here's a little video. How do you play it? Can you hear that? All right. So this is the calf, okay? Here's his knee. So you're looking at him kind of this way. So here's the incision. Turn it up. All right, I'll just talk into it. So this is where the fascial band lies from the proximal fibula over. It's almost indenting the nerve, if you can see, okay? So I kind of look proximally, and I release it. So the sciatic comes down and branches to the posterior tibial nerve, and I try to trace it all the way out and make sure that it's decompressed. And then you follow it distally and go through the other two fascial bands and release it, and then you can see the superficial and the deep. So this is a superficial branch with small motor branches go to the anterior compartment.
Is that atrophic appearing to you?
This is a deep branch. No, this one actually, I thought looked pretty healthy. What you do see is, this is where the peroneus longus tendon, okay, like fibrous tendon kind of touches it. And when it slides in there, that's usually the side of the contraction, okay? So there was sort of an indentation. I thought this one looked pretty healthy. This patient had a good outcome. I have seen them where they look different. So I went back and I started to look at, in my experience, and I think over the last like 6 or 7 years, I've actually done 42 of these cases because I kind of started looking for them. The age range from 17 to 77, and this is interesting. The 17-year-old was actually one of the first ones I did. She came in with pretty much a foot drop. She had numbness and weakness on the top of her foot. We imaged her back, I was looking for instability, pars fractures, anything. I imaged, we got an EMG and it demonstrated that. I also imaged, her hip. I was looking for anything with sciatic nerve or nerve sheath tumors or anything, pretty much all the way down. And it turned out to be compression of the peroneal nerve. And I did the surgery, and she had immediate recovery, actually in the post-operative. I was kind of sweating now, to be honest. But otherwise, 17 of my cases have been isolated peroneal nerve. I mean, they come in and actually find that that's the primary pathology, okay? 2 patients have actually had it bilateral. One of these, like I mentioned, was a ganglion cyst coming from the proximal fib joint, and this was actually the wife of one of the ER physicians that I worked with. And it was quite extensive. It came out and grew around the nerve. I had to kind of peel all that stuff off. 25 of the people in my that I've done are post-lumbar surgery, okay, who don't really make a full recovery or still have some type of issues with the nerve. And these are people that I would kind of in the past say, well, the nerve was insulted, we got to give it time, things like that. But I was actually able to find this. And out of those, I've only had one case that really didn't make that big of an improvement. And this is one when I went in, the nerve looked atrophied, it was white, it was not healthy, it was fibrous. But other than that, I have seen I don't know, the word fool is kind of difficult, but I've definitely seen a recovery of motor strength, diminished pain, and increased sensitivity, like, the numbness starts to move. So I've been very pleased with this. So I think so my goal of this is just to kind of relay that, like, just kind of put it out there in people's minds to keep looking at these patients. Any other questions?
Where did you learn to do the surgery? We have, and I say that meaning, one of my colleagues, Serena L.E., does, as a neurosurgeon, does peripheral nerve, did a peripheral nerve fellowship, and I just sent them to her. I'm just curious. I never did one in residency.
I never did either. Dr. Susan McKinnon, okay, has got YouTube videos. You can learn anything. So So I just watched it over and over. I read, I called some people. I have a friend up in Wisconsin. It's quite straightforward.
Yeah.
I'm also pretty comfortable operating around the knee.
It looks like an ulnar nerve technique.
That's exactly what it is.
You know,
kind of
except
where
you don't
you're
have to
at, you find
transpose
it.
it or anything else. Yeah,
That's
but it looks
exactly
like
right, yeah. It's actually quite fun and it's kind of rewarding.
Well, that's why I say to Bill.
I don't have to wear a cooling vest and I don't have to wear my like loops and a headlight and all that stuff too, so I can sit down. I realize why the hand guys are so happy all the time. I come out of there, my back's killing me. So, yeah.
So in the upper extremities, there's this concept of double crush syndrome,
Yeah.
You've got a C6 compression and then you've got something in the hand as well. And I'm not certain if this is really existing or not, but it's out there in the literature. And then people who don't get better after carpal tunnel release sometimes are found to have a radiculopathy. And you're supposed to look at that and fix that as well. So I wonder if some of your lumbar spine patients can have double compression.
Yeah, I think, well, that's exactly kind of, my thought behind this, okay? We do, I guess my point is, there's quite a bit of literature out there as far as carpal tunnel syndrome with C6, okay? Like upper extremity double crush, peripheral nerve type of phenomenon, okay? But it's very, very limited in the lower extremity. And I think the same process applies. And it's just been something I've sort of, like tripped upon maybe, I don't know. But I've run it by, I have a whole bunch of spine colleague friends, that we run difficult cases by and all this, and they're all over the United States, and I bring this up to them, and they don't really know much about it. Yeah.
Your electrophysiologic studies are abnormal in older patients. And the reason I'm asking that is I'm not questioning you, but in contrast to the carpal tunnel, so the way I'm understanding this is that if your patient doesn't make an expected improvement after surgery, take your 25 post-lumbar surgery patients, do you automatically basically then go right to EMG and CV?
I do. I usually wait, at least 6 weeks or 8 weeks. I wait a while. It increases the accuracy of the study itself, but I give them time to recover.
Or are most of them positive? That's what I'm
Yeah,
asking.
yeah, they've all been positive.
They all
I don't
been
think I've
positive.
operated on one that I haven't been able to demonstrate some type of objective finding.
So in contrast to the carpal tunnel, then if all else fails, definitely then go to the electrophysiologic here.
Right.
Okay.
I want to suggest that I think it is a double crush, but I want to point out, we're operating on older and older patients. They have, and I try to tell them this, they have hip disorders coming in. They have sacroiliac joint disease, hip disorder, knee disorder, may have a peroneal, ankle problems, and a lumbar spine problem. And I tell them, you have all these problems, we're going to take care of one, but I always try to leave the door open if they need something else to be done and set the expectation that they're not going to be 23.
They've got 99 problems.
That's just depressing.
You should probably publish that. Write this
I've
up.
been thinking about it, actually. It's going to, it's kind of where I'm thinking about going. Jim?
Just a few thoughts. When I was super young in my career, I found myself operating on one of these, having never seen it in residency. And I didn't find any YouTube videos at that time, and it was just textbook, and I found myself in the middle of doing it. Saying, what am I doing?
Yeah.
I'm, neurosurgery rather than ortho, so I'm not, never operated near a knee. Patient did fine, thank goodness, but I've never done it again. But there was just nobody locally who was doing these.
Right.
So my first question for you is, how long are you waiting from the time when you make diagnosis to offer them surgery? That's one question. The other was just one experience I had. First time I saw this clinically was a patient came to me with an EMG and a lumbar MRI. Guy had a painless foot drop. And an EMG that said he had an L5 radiculopathy, and I wasn't convinced by the imaging.
Right.
And it was a small town, came an RDoc that had done the EMG. So I repeated the study with my trusted neurologist, and it came back a totally different result on the EMG. It came back peroneal nerve palsy. My clinical diagnosis was right. At that time, I was waiting 3 months to offer surgery. Guy's foot was better within the 3-month period of time. So typically, I've been doing that. I don't offer any surgery or a referral till, like, give them 8 to 12 weeks to recover on their own. I personally had this myself.
You did?
Yeah. I bought a new car. I was leaning my leg up against the side. It was injuring the nerve every day as I was driving to and from work, and got out of my car, and my foot was weak and numb, and it was better within 2 weeks.
Yeah.
But anyway, how long do you wait?
So I guess to answer the first part, I didn't just delve into these surgeries by myself. I had a partner who's, he's a foot and ankle, and he said I've done like 2, and another partner who does total joints, and he'd done like 2 in his career. So I spoke it over with him, and one of them came in with me and things like that. We all read and kind of prepared in the same way, but it's not like something we routinely did. As far as how long to wait, I think it really has to do with what's going on, right? Like if they've had a clinical drop foot for a substantial period of time, and I had fixed their back, and I'm not seeing the recovery that I kind of wanted, okay. I think in those people, I'm a little bit more aggressive. And somebody like community ambulator who's, felt it in their car, that's someone I would really try non-surgical care. But I also think that, the motor weakness is a driver for me, right? Like, it's kind of a race now. The nerve's not working. It's injured to the point where we're getting atrophy of the muscle, and even if we get neurological function back, are we able to restore, actual function? So if I'm seeing weakness, I'm pretty aggressive at those, to be honest with you.
Two other things.
Sure.
We try to discriminate L5 from peroneal nerve.
Yeah.
I've given up. I memorized that for the boards, and that's about as useful as it's been since then. Do you apply, the difference between foot eversion between an L5 and a peroneal nerve? You just use clinical. And then the other thing I want to say, Janelle's test there, as you check the knee reflex, just go lateral. That's what I do.
Right.
Just whack that whole area with the reflex now.
Yeah. Yeah, I use my hands for reflexes, okay? I saw a surgeon do that once, and first I thought maybe he was lazy, right? Didn't go get his hand up, but I realized what he does is he's developed his ability to do it. And you're not coming in a patient with a hammer, right? They're still relaxed. I'm messing with their knee. Okay, got it, right? So the same kind of thing is go over. But how to differentiate that? It's really difficult. I really use like the dermatomal pattern of their pain. I ask them then, where's it go? Where's it go? Where's it go? Like, the foot is what demonstrates it, right? For me, medial problems are usually 4, top of the foot 5, lateral foot's S1 in general. And most people you have to kind of get them to think about it, for them to decide. But in general, I think it's parallel exam, right? It's the same nerve. So butt pain, okay, I don't see a lot of like gluteal pain with this, okay? So like, that's my first, so if I'll say I do, I don't know, 4 or 5 teeth, or 5, 1, whatever, I decompress the 5 nerve. They say, oh yeah, my back's better, this is better, but I'm still having it down here. That's kind of a clue, right? That's a clue for me. So.
Thank you.
Right. Thank you.
Our next speaker is Michaela, and she comes to us from the University of South Dakota. Appreciate you coming to present to our academy. Thank you.
Alright, thanks everyone. My name is Michaela Derby. I'm a third-year medical student from the University of South Dakota, Sanford School of Medicine. And today I'm presenting on wide-awake hand surgery in a hospital-based procedure room, and this is our experience. We don't have any disclosures. So some of the frequently asked questions of wide-awake procedures. Does this work? Is it safe? Do patients like it? Does it make financial sense? Before we start, there's something important we need to discuss. Now that we're all wide awake, what is WALANT? Wide awake, wide awake procedure with lidocaine as the anesthesia, and there's no tourniquet. So we don't have to use things on the left we use in the operating room. WALANT uses 1% lidocaine with epinephrine. The lidocaine and epinephrine are used for the local wound hemostasis, means we don't have to use a tourniquet, it's safe, and allows procedures to be done outside of the main OR. So here's some examples of what we can do with wide awake. We have the trigger finger, carpal tunnel, Dupuytren's, and CMC joint arthroplasty. In the past, we've used the tools necessary in the operating room, but now we don't have to. We can now perform trigger fingers, Dupuytren's, and carpal tunnel in the procedure room in either the office or the hospital. And here is a ring finger transfer for a FPL laceration. And it's pretty cool, the patient can see exactly how you're doing during the procedure. Here's another example of an in situ cubital tunnel decompression done under wide awake. So for the purposes of this project, we're moving from the main operating room to the procedure room. And with this, we have cost savings, patient safety, and high patient satisfaction. So it comes with the question of lidocaine safety. In the past, we've been told lidocaine with epinephrine is a crime. We were also once taught that the world was flat in the 1940s and not to inject epinephrine into the finger. So this definitely comes with some angst. So some safety concerns. There's a dogma in reality. What are people really concerned about? And there, in the hand literature, there's evidence that this is a safe procedure with epinephrine and lidocaine with use in the hand. And there is a study with over 3,000 cases with use of the epinephrine and lidocaine where it was safely done with good outcomes. So in some cases, we do need to avoid the anxious patient. And one thing we can do is use the operating room. That's always plan B. So here's a study from 2020 where ASSH members were surveyed. There was about 4,000 members, 896 responded, and only 62% of these individuals use wide awake procedures in their practice. So our orthopedic group at Sanford, we're based out of Sioux Falls, South Dakota. There's 20 orthopedists, 5 hand surgeons, and on the right we have the 2 in-office procedure rooms. I was specifically looking at the outcomes within the hospital procedure room for this study. So here's our hospital procedure room. Methods, we had 786 patients, 948 elective hand procedures. They were done between 2019 and 21. And we were looking at the post-operative complications. So here's our survey. We had a post-operative patient satisfaction survey. The infection rate was evaluated. And then we have 376 carpal tunnel procedures, 174 trigger finger, 69 mass excisions, and 57 Dupuytren's. As you can see, carpal tunnel and trigger finger were the most common procedures included. We had 59 patients with infections. There was a 6.2% infection rate, and then carpal tunnel was the most common infection, and all were superficial. Infections were managed with antibiotics and soaks, and you can see the proportion of infections really went up with age. And then 3 patients required return to the OR for irrigation and debridement. So here's our survey. We asked, how would you compare your experience today to going to the office? Would you recommend a procedure done in this room under wide awake to a family or friend? And would you do another procedure in this room under wide awake anesthesia if you needed it? And overall, our survey responses were very good. 99% found it better, same as the dentist office. Similarly, would return to this procedure room again for a wide awake operation and would recommend it to a family or friend. Interestingly, we had 142 repeat customers. Here's the equipment currently used for a carpal tunnel release. The back table here costs $38. And we also looked at it, we did a QI project called the Lean and Green, and we were looking at creating new surgical packs and evaluating the cost and trash savings. So in this project, on the right we have the pre-op carpal tunnel release table before the project, and then here we have after we started the project. So you can see there's a lot less supplies here. It was about $10 a case in savings. And even better, before and after, there's about a 5-pound trash reduction after this project was started per case. So since 2014, savings has been about 100,000, and the trash savings has been amazing. So as we've seen already, Michael Porter, he's the face of the value-based healthcare equation. And here is Herb Stein. He served in the Nixon and Ford administration, and he is an economist and actor, and he's known for Stein's Law. And then here is Ben Stein. He is his father. So, not surprisingly, Mr. Stein, he was a great actor. What's maybe more surprising is that I have seen this movie. So, in 1986, he presented Problems and Not Problems of the American Economy, and included in this, he talked about questions of trade and budget deficits. And he said if something cannot go on forever, it ought to stop. And I think that's where we are in healthcare today. So in summary, Wide Awake works in the hospital procedure room. It's safe, cost effective, has high patient satisfaction, and is resource friendly. Thank you for your attention, and I wanted to thank Dr. Demark, my mentor, and I'll take any questions.
So I have a question, and maybe Dr. Vandermark might also answer this. Is there a difference when you use a local anesthetic with epinephrine? Does it matter whether it's lidocaine or marcaine? Not in terms of the toxicity, but in terms of the risk profile of one over the other with respect to circulation.
Yeah, I think lidocaine, I think is the preferred drug. Don Lalonde makes a big point. If you ever get injected with marcaine, your finger stays numb for hours. People don't
bring this up is because,
One, don't discount Percept and the Lean Green Initiative. Hospitals, as it turns out, generate more pounds of garbage for anything than any other industry. I think that's very important, and frankly, I'm encouraging you to publish it. Second of all, you saw the Ferris Bueller movie. Most of us have seen the Katy Perry video. It goes both ways.
The only comment I would make is that depending on why you go to a dentist, because you're comparing this to the dentist office, if you're having terrible mouth pain, anything is better than going to the dentist. So, you know, I'm not sure if you just say go into a regular office, you know, because some people equate dentistry with severe pain. So obviously, you would expect your answer to be 99% in favor. But
You think 100%?
I think there would be anyway.
No, but it's not. We had 2 people who thought this was terrible.
Really?
Of course,
Yeah.
they're not very happy anyway, so I was.
You know, I've come across over the years, once in a while, you find somebody
Yeah.
that just, you know, that goes miserable, the fact that they can hear me, you know, whatever.
That is one thing, Jeff, from one of your patients.
Yeah.
Once I was doing one, I said, bipolar? He goes, my wife thinks I am.
All right, we have Professor Van Demark again speaking.
I was telling Michaela last night, I recorded that video at home, Katy Perry, and so I was on recording it. My wife comes in, what are you doing? I said, well, this is for talks. Sure it is. So. Let me get started here. So we'll talk, my last talk here is about Lacertus syndrome, and this is the other median nerve problem that we see. I have no disclosures. We'll talk about what is Lacertus, how to diagnose it, treatment, and outcomes. And if you're not a hand surgeon, you probably wonder what the heck is this. So we'll try to explain what Lacertus is. Probably the best way is a case presentation. This is Don WALANT, who's a hand surgeon. And Don had 2 carpal tunnels done on the same hand and still had persistent symptoms. So this is Don's YouTube video. So I'll let Don present his case of Lacertus. We'll see how the volume works on this. Anything.
In a young woman in whom she had demonstrated weakness of flexor carpi radialis, flexor pulsus longus, and flexor digitorum profundus of the index, preoperatively, just as she demonstrated it to me in Vancouver because I had the same symptoms. Here she is examining that same patient immediately postoperatively, showing return of power of those muscles. The return of power in this patient was very impressive, particularly in view of the fact that doing this operation with a wide-awake approach made it a simple 5-minute procedure like carpal tunnel surgery. Reading the excellent papers published by Elizabeth and her father, Carl Harder, also helped convince me that a good simple first step to releasing pronator syndrome was simply to divide the Lacertus. If that didn't work, I could still do the large operation for pronator syndrome, which is frequently described.
He has weakness of his left hand and his left wrist. And this is a weak left thumb FPL tendon. least 10 yards a week. And she's going to pinch his median nerve on the left side. And he'll kind of lurch when she does that.
It was really tender when she pressed on my median nerve under the Lacertus. And if patients have this tenderness sign, weakness of FCR, FTP2, and FPL, I am now willing to operate on them. They may also have numbness in the ulnar cutaneous branch of the median nerve, as well as persistent numbness after carpal tunnel release, as I had in my left long and ring fingers.
This is immediate post-op.
I got an immediate return of power right on the operating table and in this immediate post-operative examination.
So Don has a YouTube video of this if you want to see it on YouTube, down the line. So we'll talk about the proximal median nerve compression. This has gone by the name of pronator superficialis syndrome. It's also been called the Lacertus syndrome. And pronator is defined by median nerve compressed in the proximal forearm. Dr. Haggart, who also has a nice YouTube channel on this, has described this as compression in the median nerve as it passes beneath the Lacertus fibrosis, more proximal. So are pronator and Lacertus twins, or are they brothers from different mother? And I think sometimes the terminology can be confusing. Dr. Jim Botain has said, which I think is true, Lacertus should be defined separately from pronator, two different areas. Pronator was first described in Norway in 1951 as median nerve ischemia. It was due to disorders due to strain. They had 17 patients that were all treated with Novocaine. This will show you how old this is. And they were all better after their injections. In 1981, the Mayo Clinic published their series of 36 cases of pronator treated with surgery. They found multiple areas of compression and performed a wide open decompression of the nerve. They had the usual orthopedic results. 78% were excellent and good. 5 were fair, and 3 were unchanged. So there are really 5 potential sites of compression in the median nerve: the ligament struthers, the Lacertus, pronator teres, the FTS arch, and Ganser's muscle. The ligament struthers is rare with the supracondyloid process. The only one I've seen is on recertification examinations, so it's a great test question, but you never see it in person. We'll talk about the Lacertus. The nerve can be compressed as it goes between the 2 ends of the pronator, and the FTS arch has also been implicated as a potential source of compression. And finally, is Ganser's muscle, which is an accessory head of the FPL. So why is this important? This is a large series from the UK of carpal tunnel patients with surgery. About half of the patients thought they were cured. About 30% thought they were better, but 22% were not great. And I just wonder if a lot of these people have undiagnosed Lacertus. It's an easy diagnosis, it's a clinical diagnosis to make based on history and physical, and nerve studies are not too useful for this. Dr. Hager published her series of 388 Lacertus releases. 275 of those were combined carpal tunnel and Lacertus, and about 13% had failed carpal tunnel surgery previously. And these symptoms are a little bit different for Lacertus. Patients complain of loss of hand strength, loss of endurance, and forearm pain. And with a combined Lacertus and carpal tunnel, they complain of numbness. So the examination, we all know the sensory exam for the median nerve. They have weakness, like Dr. WALANT did, of the FPL, index profundus, and FCR. They can have a positive scratch collapse test and have painful median nerve at the elbow. If you do a cross-section of the median nerve at the elbow, the superficial fascicles include the FCR, the FPL, and the index profundus. The scratch collapse test has been described by McKinnon in 2008. This is from her article, and I'll show you a video. This is John Paul Brutus from Montreal doing a scratch collapse test on the left arm for both median nerve at the wrist and the Lacertus. And he'll scratch the nerve as he does it, so we'll see if this works.
Demonstrate the scratch collapse test. Yeah. So keep the position as you know. I'm going to push inward, and you just push this. Perfect. I'm going to stimulate the left carpal tunnel area and this piece. Oops. The positive collapse test. Now I'm going to make sure that the force is back, the strength is back, resisting. Very good. Now I'm going to stimulate the Lacertus fibrosis area, and we repeat the test. Resist. No more strength.
You see the arm collapses. And it's really interesting because we do it to the patients, they kind of like, oh, what was that about? It's very unexpected for everybody. And also painful median nerve compression. So, and just keep in mind that you can have both carpal tunnel and Lacertus in the same patient. One series was up to 13%. So I always test people's strength of the FPL and kind of do the exam for carpal tunnel patients because a lot of people will have it. Treatment, conservative measures up to 70% success rate, can take a long time to get better, including non-steroidals, rest, activity modification, and cortisone injections. The treatment historically surgical has been median nerve decompression with wide exposure. This is from Green's textbook. It's kind of like a shark bite wound going from the Lacertus all the way down to the FGS arch. The other option is a wide awake decompression, as Hager has suggested, using local anesthesia at the Lacertus and incising the Lacertus. In her series of 275 releases, 91% of those were done with just straight local anesthesia, and 99% of people got immediate return of power. Bernie Heron from Wichita published his results last year of 12 cases of Lacertus. 10 had previous failed carpal tunnel surgery and had follow-up their symptom-free in 5 years. And he makes a big point that you have to look for this to find it. If you don't think about it, you won't find it. So overall, the numbers for surgical improvement range from 71 to 93%. Wide decompression is up to 92%, and the Lacertus is 93%. So I would ask you, why would you do the operation on the left when you can do a 5-minute local operation on the right with the same results? And Hager makes a point of not really calling this pronator, but symptoms of pronation, which seems to irritate the nerve with the arm pronation. The summary, Lacertus is common. It's a clinical diagnosis. And I think you should think Lacertus if you have a patient with carpal tunnel story with normal nerve studies, or forearm pain and or hand fatigue, or failed carpal tunnel surgery with persistent symptoms. And I would suggest that wide awake surgery is a much better way to take care of this as opposed to the old open decompression. And as a final point, you just have to look forward to find it. All right, any questions?
A question for you.
Yeah.
Now, is this similar to the anterior osseous nerve impingement?
Right.
Okay.
Yeah.
Same.
It's the same finding, yeah.
Same. Okay.
But you have pain up here and you have scratch collapse test.
Okay.
Yeah.
Thank you.
Yes.
Explain that scratch collapse test.
article in 2008 by McKinnon, and the theory is it's caused by allodynia, and they did this in rats. And if you irritate the muscle, the nerve in the muscle, it's a reflex that you try to protect that extremity. You'd have to read the article to get the full explanation. Some people don't believe in this. It's okay, but when you do it a couple times, because you don't know what's going to happen, and the patient doesn't know what happens, all of a sudden it happens like, oh. Yeah, try it, it's crazy how it works. And you can do for ulnar nerve and for carpal tunnel too. Yeah, that's 2008, general hand surgery. And she might have a YouTube video about it too.
She might.
Yeah.